Assalamu alaikum and good morning, everyone. It's very sobering to see a full house today. Dr. Sianus concluded his talk by saying that there isn't a great evidence to help us actually in some of the situation within a STEMI. So wait until you see what I had to share with you with a STEMI patient. So does a STEMI with surgical anatomy represent a clinical concern? Is it really a big issue in our clinical practice? And is there any good clinical evidence to guide our judgment in day-to-day practice? And I will share with you what the most recent STEMI guidelines had to offer us. I'll start with a case that I'm sure lots of you will relate to. It's a 77-year-old man with diabetes, hypertension, and dyslipidemia, a very good functional capacity. He presented late with inferior STEMI with mild ongoing anginal pain. This is his culprit. It's totally occluded. You can see some clot in the mid-RCA. This is his left. You can see heavy calcification, distal left main diffusely disease, subtotal occlusion, trifurcation, severe disease involving all branches, and diagonal as well from that LAD. And you can see the LAD itself has actually very long lesion involving proximal to mid, close to the distal area. So just for the sake of time, I was hoping that we can actually take a vote on the approach in this clinical scenario, but I'll just share with you the potential scenarios that can be done at the cath lab acutely, and probably we can go back to the case after I finish and we'll discuss it with you. So what would be the option? To restore TIMI 3 flow with thrombectomy, PTCA of the culprit, followed by surgical referral. Would anyone do ad hoc heart team meeting in the cath lab if it's during the daytime, or just perform primary PCI to the culprit, the referral for inpatient cabbage, or do primary PCI to culprit vessel, then stage inpatient complete percutaneous revascularization. Now, acute MI with surgical anatomy is not uncommon, and we know that complexity of coronary disease has significant impact on long-term outcome. And at the same time, completeness of revascularization has actually a major role in that outcome. Now, with regard to the acute MI, we know that timing of revascularization is paramount. What do you mean by surgical anatomy? I think we can probably all agree that the best way to assess surgical anatomy, the complexity, is utilizing syntax score. We all know that it's either low, intermediate, or high. And actually, when you look at the guidelines, it's recommended to be calculated as class 1B for the surgical risk as well as complexity assessment. But remember that syntax trial, from which actually this score was derived, they excluded acute MI. So this is in a stable patient. What's the prevalence of complex CAD and STEMI? Patient with left main, concomitant left main disease and acute MI reporting different seizures up to 7 to 8%. Multivessel disease can be seen from quarter up to half of those patients in the STEMI setting. I looked carefully in our region. I'd expected actually about 50% multivessel disease, but I found one large volume center from the western side of the country that they reported 4% left main disease involvement and just only 15% multivessel disease in the STEMI setting, but I thought it's probably underreported. Multivessel disease in the STEMI setting is associated with outcome, and that's actually across most of studies and registries. This is just a quick reminder of the revascularization trial, and as I said, syntax, recombinant noble, Excel, as well as a recent meta-analysis that combined all these trials. Most, actually all of them, they excluded acute MI. Why surgical and complex anatomy is a concern? You can look from the infamous syntax trial that the outcome in complex anatomy in a stable patient is very poor for patients who underwent PCI convert to cabbage. And even when you look at the most recent meta-analysis that looked at all these major trials, although the outcome, all-cause mortality actually become non-significant at 5 years, but still you can see that one of the important driver actually of outcome is repeat revascularization, and there's a huge difference between complex anatomy and non-complex anatomy, and actually even those with low or intermediate syntax score, actually they still had more repeat revascularization. Now, when you talk about in STEMI patients, oftentimes you will come across non-feasible PCI. So what do we mean by that? This is a large cohort from the ACTION database that looked basically at patients who did not undergo PCI. Now, that publication basically looked at about 220,000 patients, and when they looked at patients who did not undergo immediate revascularization, about a third of those patients was deemed to be because of complex anatomy. And if you look at the outcome actually in terms of reperfusion versus no reperfusion, those patients with three-vessel disease actually represented almost 40% of non-reperfusion, and more of those patients actually were referred to CABG. Okay, you can see 3.5 in the whole group versus almost 20% in patients with non-perfusion, and you can look at the outcome. Mortality actually is almost 4 times higher on those patients who did not undergo percutaneous revascularization. So what's the optimal timing for coronary artery bypass? Now, the reason I'm just looking at the surgical option, because we all agree, if you can open the vessel, it's no brainer to just go ahead and do primary PCI. But what if you're stuck? What if you could not do it? And you had only the surgical option to return to. So I will just go through the database in chronological order. So I'll go to relatively old data, sort of medium range, and more contemporary data. Looking at a large database from California DSAR database, they looked almost close to 500,000 patients from 1999 to 2005 with acute MI. Over 9,000 patients underwent CABG, and they looked at the outcome based on the timing of CABG, early within 2 days and late after 2 days. And you can look at the outcome. Mortality actually was very high. If it was done early, you can see day 0, 1, and 2. The mortality was 8%, dropped to 4.5, then 4.2. Anything after day 2 or day 3 onward actually seems to be a reasonable outcome of the patient required urgent surgical revascularization, yet to go up again after 1 week. And when they looked at those patients with high risk presentation, shock, or those patients who required intra-aortic balloon pump, which was a common practice back then, also those patients who underwent early revascularization had poor outcome. When they looked actually at the propensity adjusted multivariable analysis, timing of CABG is actually important implication on the outcome. This is another cohort from the national inpatient sample, which is also a very large database in the US, and they looked, that's STEMI patient, included almost 6,000 patients, and you look at the time of intervention, surgical intervention, you can see the complication is much higher. When you look at the mortality, you can see, again, similar to the previous cohort, it's almost 8% if intervention was done within the first 24 hours. Moving on to more contemporary cohorts, and that's all-comer patient with a STEMI patient or ACS in general in 4 academic centers in Germany. They looked at the outcome extending from 2010 to 2017. And the beauty of these publications is actually all-comer. This is real data outcome. 23 of those patients underwent urgent CABG within 24 hours of symptom onset, and almost 70% of STEMI patients underwent CABG within the first 24 hours. In terms of complexity, you can see in the STEMI patient, 80% of them had multivessel disease, and almost close to half of them had left main disease. And those patients represent a very high-risk patient. When you look at the outcome, you can see, just focus on the STEMI bars, you can see that the hospital mortality was 12.6% in the STEMI patient. When we look at the surgical intervention in those patients, based on time, can see that in STEMI patient, the mortality, if it was done within 24 hours, jumped to 15.4%. The same group, basically, they just looked back at the same database and looked at those patients who either had successful primary PCI and they had an indication to go for urgent CABG, or those patients who did not have successful primary PCI, and they said they represented around 15%. For the sake of time, I'll just show you the outcome, and they looked at the outcome based on no PCI, PCI within more than 24 hours, less than 24 hours, or those patients who had failed PCI. You can see in the STEMI bars that those patients who had intervention early on had a very significant mortality. You can just focus on the in-hospital mortality, which was 21%, 15.8% in patients who failed primary PCI or they had primary PCI, but they had to go for surgery early on. So I'll sum up with the most recent guidelines. This is what the guidelines offer us. So basically, if you had STEMI, you have to fix the culprit. This is class 1A. But what if you could not do it, or if unsuccessful? They said that coronary bypass grafting should be considered in patients with an occluded infiltrated artery when primary PCI is not feasible and successful, as long as there is a large area of myocardium in jeopardy. So to sum up, no RTC or high-quality evidence regarding STEMI and severe multivessel disease. The number of patients who ultimately require surgery is still actually, I would say, visible. It's not low. In the setting of STEMI, CABG can be considered only if the culprit cannot be fixed, and the area at risk is large. And you have to remember the risk of emergency CABG in surgery patients failed is still very high. Early CABG seems to carry the worst outcome. And if those patients can be delayed more than 2 days, probably those patients would drive a benefit. Thank you so much.